All right, so if you're a pathology trainee, this one's for you. We're going to break down the College of American Pathologists protocol for one of the biggest deals in pediatric pathology, neuroblastoma. Think of this as your step-by-step guide from the moment that biopsy hits your desk to the final diagnosis.
Okay, let's dive right in. Picture this. You get a small blue cell tumor biopsy from a kid. Neuroblastoma is screaming at the top of your differential. So, what now? Well, this guide is your roadmap. We're going to walk through everything, from the gross bench all the way to that final synoptic report, hitting every single key decision point you need to know.
So we've broken this down into 5 key parts. First up, the protocol and how to handle the specimen itself. Then we'll get into the 4 main histologic types. After that, we'll talk grading, differentiation, and this thing called MKI. Then the big one, pulling it all together for the INPC prognostic groups. And finally, we'll wrap up with the essential molecular studies.
All right, let's kick things off at square one, the protocol and the specimen. Seriously, how you handle that piece of tissue when it first hits your lab is, well, it's everything. It sets the stage for every single thing that comes after.
So, the CAP protocol is super clear about your priorities. Job number 1, get that formalin-fixed, paraffin-embedded tissue for your H&E slide. That's the bedrock of your diagnosis, right? Only after you've got that squared away should you even think about setting aside tissue for molecular studies. Morphology first, always.
And here's a huge heads up. This comes straight from the protocol. These tumors can be a total mixed bag, super heterogeneous. You might get a small needle core that looks great, all well differentiated, but you could be completely missing a nasty stroma pore nodule just a few millimeters away. So what's the bottom line? If you're dealing with a small biopsy, you absolutely have to put a comment in your report saying that your classification could be limited by sampling.
Okay, on to section 2, the 4 main histologic types. And here's the secret, the thing you have to burn into your brain. The key to classifying these tumors isn't really the neuroblasts themselves. Nope. It's all about the background. It's all about the stroma.
So it really boils down to this one simple question. Is more than 50% of the tumor made up of the Schwannian stroma? If the answer is no, you're in the stroma poor category. If it's yes, you're in the stroma rich or stroma dominant camp. That one distinction, right there, is the first huge fork in the road for your diagnosis.
So let's start with the classic, neuroblastoma. This is your quintessential stroma poor tumor. You'll look under the scope and see those nests of neuroblastic cells, that classic neuropill, but the key is that the supporting Schwannian stroma is minimal. It makes up less than half of what you're looking at.
All right, now let's flip to the other side, our first stroma-rich example. This is ganglioneuroblastoma intermixed. Here, that Schwannian stroma is everywhere. It's way more than 50% of the tumor. But, and this is the important part, you can still find these little microscopic nests of neuroblasts just kind of sprinkled throughout that mature stromal background.
And here we have the most mature, the most chilled-out version of these tumors, the ganglioneuroma. This is what we call stroma dominant. I mean, it's almost all Schwannian stroma. You'll see some nice mature ganglion cells scattered around, but the absolute key here is no neuroblasts. None. That complete absence of neuroblasts is what makes this a fully mature, benign tumor.
And last but not least, we've got the trickiest one, ganglioneuroblastoma nodular. You can think of this as a composite tumor, kind of like a tumor within a tumor. You've got this nice, mature, stroma-rich background. But then, boom, inside of it, there's one or more distinct nodules of stroma-poor neuroblastoma. And this is exactly why that sampling issue we talked about is so critical.
Okay, moving on to section 3. So, now that you've identified that neuroblastic component, whether it's the whole tumor or just a nodule, you've got to grade it. And that grade is based on 2 really important features: how differentiated the cells are, and something called the mitotic karyorectic index, or MKI for short.
First up, differentiation. Think of it as a spectrum. On one end, you have undifferentiated. You see 0 neuritic processes, no neuropil. Then, in the middle, you've got poorly differentiated. Here, you'll see some neuropil, but less than 5% of the cells are actually maturing into ganglion cells. And that 5% number, that's the magic number, because if you see more than 5% of cells maturing, you get to call it differentiating. The second part of the grade is that MKI. This is basically a measure of how fast the tumor is growing. What you do is count both the cells that are dividing
the mitotic figures, and the cells that are dying, the karyorectic cells. You count them up in a field of 5,000 cells. The cutoffs are pretty simple. Less than 2% is low MKI, between 2 and 4% is intermediate, and anything over 4% is high. And believe me, this number is a hugely powerful predictor of how the tumor is going to behave.
Okay, this brings us to the grand finale of our histology workup, Section 4. This is where we take all the pieces of the puzzle we've collected, the patient's age, the histologic type, and that MKI we just calculated, and we put it all together. We use the International Neuroblastoma Pathology Classification, the INPC, to assign a final prognostic group.
You can really just think of the INPC as an algorithm. It's got 3 inputs: patient age, the histologic subtype, and the MKI category. You plug those 3 things in, and it spits out one of 2 answers. And these answers have massive clinical weight, either favorable histology or unfavorable histology. So let's look at an example to see how this plays out. Take a really young kid, under 18 months old. Even if they have a poorly differentiated neuroblastoma, it can still be called favorable, as long as the MKI is low or intermediate. But look what happens the second that MKI jumps into the high category. Bam! The prognosis immediately flips to unfavorable. Doesn't even matter what the differentiation looks like.
Now check out the complete contrast for an older child, say 5 years or older. For them, it doesn't matter. It doesn't matter what the subtype is. It doesn't matter what the MACI is. Any neuroblastoma in this age group is automatically, straight up, classified as unfavorable. This just hammers home how incredibly important the patient's age is in all of this.
And that leads us perfectly into our final section. Look, histology tells us a massive part of the story, but it's not the whole story anymore. In the modern era, molecular genetics gives us this other absolutely essential layer of information for figuring out a patient's risk.
Now, there are a bunch of molecular tests out there, but you can really think of a big 3 that are critical for risk grouping. The undisputed heavyweight champion is MYCN amplification. Then we also look for ALK mutations or amplifications, and some specific big chunk chromosomal changes like deletions on chromosome 1p or 11q.
So what exactly is this MYCN thing? Well, it's a proto-oncogene, and when it gets amplified, it means the cell's making way too much of it. This basically floods the cell with signals that slam the brakes on differentiation and hit the gas pedal on proliferation. To be blunt, it is one of the single worst prognostic markers in all of pediatric cancer, period.
Okay, so when you get that FISH report back, you have to know the lingo. It's critical. Amplification has a very specific definition. The number of MYCN signals is more than 3 times the number of signals for its home chromosome, chromosome 2. Now, if you have extra copies but you don't hit that 3-to-1 ratio, that's called a gain. And honestly, we're still figuring out what that means prognostically. But that distinction between amplification and gain is absolutely vital when you're writing your report. And if there's one thing you remember about the molecular side, let it be this: MYCN amplification is the ultimate trump card. It is so powerful that it can take a tumor that looks totally favorable down the microscope and instantly rocket that patient into a high-risk clinical category. The bottom line, molecular status can and very often does override histology.
So there you have it. We've walked through the whole current standard from stroma, MKI, all the way to MYCN. But, this field is moving at lightning speed. So the final question I want to leave you with is this. As we get better and better at understanding the genomics of this disease, what do you think the next generation of classification will look like in, say, 10 years? Something to think about. Thanks for tuning in.